to get, if we ever want to get what we want to move to the next level, we have to recognize, I was talking to fellows about this, that nobody's like, I wonder if the laryngoscope works at getting a tube in the airway, right? What we're testing is if we can put the tube in the airway as well as the anesthesiologist. So I don't think that anybody's looking at your anesthesia colleagues and saying, hey, can they do block? Are blocks efficacious for pain control for X, Y, and Z? They kind of have an answer to that, I think. There's probably subtleties in that answer. But what we're trying to prove with all of this work is, can ED doctors be quickly trained to offer better pain control? And not, I always use the term regional analgesia and not anesthesia. I use that purposely because I think that that's our goal. Sorry. So I'm going to first talk about a study that I think is interesting. And I kind of, the slides are backwards. I'm going to talk about this slide. This is a study that was done out of, sorry, it's Oakland. Done in a journal in 2016. I really liked this study. When first time I read it, I had real annoyance by it, because I'm going to go back to the first slide, the slide before this. It's not moving. Sorry, I'm going to go back. I apologize, guys. Screen share. And see it now. Okay, so my slide's a little out of order, but this is a study. This is a regional nerve block improves pain and functional outcomes in hip fractures. This is in elderly patients. What's interesting about the study was, when I looked at the study, I was kind of annoyed that they didn't tell me if ED doctors could do this block. What it was they did femoral nerve blocks. They devised a specific amount, 0.5, 20 mLs of bupivacaine by the ED doctor in the first 12 to 24 hours. Actually, earlier than that. Then all the patients that got blocked, and they had randomized to either no block or block, then got continuous femoral nerve blocks done by anesthesia. And then they looked at pain scores very clearly, 1 hour, 2 hours. They did walking follow-ups, post-op day 2, post-op day 3, and they protocolized this. And if you look at the data, I mean, this is classically the data that I'm going to throw at you, right? At Island, at 4 hours, you reduce pain, which is interesting, but really not the way that we practice pain or practice medicine. And it's really not that interesting in the sense of the hospital. What they did is they looked outpatient. They looked at 3 days out and looked at pain in the femoral nerve group, again, that protocolized group versus the control group. And they even looked at distance walked at 3 days. So when you look at this, I think this is where we need to go as a group. And I mean this as all of us, because I think that what we're looking at is Arun can do a serratus block to reduce pain. But what I need to know is kind of how we do it as a group. And really what I'm testing is not the block, but I'm testing the user. Does that make sense to everybody? Yes, no, I'm sorry, I can't see you guys right now for some unclear reason. You guys understand what I mean?
I'm nodding.
Yeah.
Okay, good. I'm sorry. I can't see anybody because I have 2 screens up. So I think that when it comes to the way that we should be running block studies nationally and departmentally, they should be protocolized internally. So departmentally, this is something we switched now 5 years or 10 years into our game, is that all of our blocks get the same timing of pain assessments. We really should move to, if you have a hip fracture, you get this block. And not because I want to limit Joe or Carlos from doing a block that they feel is necessary, but I'll never get good enough data to show efficacy. And I'll also never ever show that large groups of ED doctors can do this. And also what we need to do is standardize who does blocks. Because what we're doing is we're testing after 5, if I get a gel phantom with resident 1, and I walk them through 5 gel phantoms, and I walk them through 1 femoral nerve block, now they're in my study. Can they do blocks with the same efficacy as everybody else? Can they still show that 50% pain reduction? And I think it allows us to kind of have a standardized way of doing all this. And I think the more we build this into our protocols, rather than we just do femoral nerve blocks, our pain reduced, 0, 1 hour, 2 hours, 4 hours, whatever the number is, standard needles, standard volumes, standard procedure types. And you've seen this, and we were just talking about this earlier. Nysora does blocks differently than Gadsden, who does different blocks than what I do. And I think if we standardize it as a group internally, I think we'll get signal and data that actually shows some efficacy rather than what we classically do. So I think departmentally, ED blocks should be standardized. I think pathways in hospital, Kaiser has a pathway, which I've asked numerous times for their research data and they haven't given to me. But they have a protocol that if a patient comes in with a hip fracture in Northern California Kaiser, they have 6 hours for somebody to do a block. I think it's maybe 3 or something. I don't remember the number. Either the ED has to do it or anesthesia does it, a single injection block. And then the patient goes upstairs and they get a protocolized catheter-based block protocol and they look at them downstream. And I think that if we don't do that, I think that's the problem. I think for us at Highland, what I see is I do a rib fracture block. Somebody comes in, and you guys have seen this. We do a block and they sit there for 24 hours. And then we're like, hey, does somebody need a block again? We should have a clear pathway. The minute that somebody does a block in the ED, anesthesia, that patient gets transitioned from the ED single injection block pathway to an anesthesia block pathway. So their responsibility is either repeat the block or come to us and ask us to repeat the block or place a catheter. And I think that's the only way that we're going to get real data. Otherwise, we're going to get all this kind of random data. And I think lastly, it comes down to our block registry. And so I'm hoping most of the people on this call are on the block registry. This is something I want to talk to Andrew about, is that we need to have something that's so standardized that when we look at what Denver's doing and what Utah's doing and what Hennepin's doing, our pathways are all about the same when it comes to everything we do, that allow us to actually get pooled data that's not heterogeneous and actually allows us to actually show efficacy. Because what we're testing, again, is not anything other than the fact that can ED doctors with a little bit of training offer optimal pain control? I'd love to hear your thoughts.
I mean, Arun, I can tell you, so from our standpoint, we're actually pretty heavily pathway driven, which is nice in the sense that once you get the pathway through, it's awesome, but it takes a while to like get the momentum to go through to that.
What's your pathway?
So we've already got one in place for geriatric hip fractures, and we're currently rebuilding general hip fractures, pelvic fractures, rib fractures, atraumatic low back pain. So that basically it'll
departmental, or is it cross departmental?
So that's when the pathway is finalized, it's interdepartmental, but it creates a couple different weird issues for us, is like to get the sign off. So that's why I haven't even bothered trying to bring the PENG block in, because it took so long to just get people to do the infrainguinal fascia iliaca that I'm just leaving that as like, that's our sort of gold standard. That's what we're doing for all of them. But it's like the hip fracture pathway is a collaboration between us and then ortho. The rib fracture is us and our trauma and acute care surgery. The acute low back pain, atraumatic low back pain is just us. So we just get to update it as we see fit. And to your point, what's nice is once you engage in the pathway via Epic, you can pull all of the data of like, when did people get into the pathway? How far down the pathway did they go? If we have like the branch points to standard non-regional anesthesia based pain control, you can cross compare and you can get all the sort of outcomes from that. I would say that the challenge we run into though is our acute pain service has basically said, if you as an emergency department stick a needle in somebody, we won't touch them when they hit the floor, which is a whole other thing on its own. But like, they fortunately, our orthopedists don't also believe in, or they don't use catheters very often, which is great because that means we can still do single injection blocks and it doesn't inhibit surgery downstream. But that's just kind of where our acute pain service falls, is they're sort of like, if you do that, we're hands off. But my hope is between like the pathway updates and our registry, to be able to come back in 2 to 4 years and say, here is now 5 years worth of data. We're not killing these people. We're not causing complications. And here's what's happening across the country. Hopefully then we can have some meaningful re-engagement about how to make this a sort of a bigger interdepartmental pathway.
Yeah, so I don't want to hear other people, but I want to point out a couple things. If I came to Highland all over again today, right, the first thing I would do is I'd build a pathway for just one injury. I'd just do ribs and hips. I'd make it really simple, right? Ribs and hips. This is what we do. This is our standard. Anybody gets a hip block. Everybody gets an infrainguinal fasciolateral block. Gets a pain score at 1 hour and at 4 hours. It's built into Epic. The nurses get triggered. Everybody's using ropivacaine. Everybody's using dexamethasone, whatever, and make it so clear, because then you have this nice feed directly into Epic that you can pull, like you said. And second, I'd have the conversation with our anesthesiologists. What do we do with those patients once they get blocked? And I think most anesthesiology groups will be happy to be like, well, fine, we'll do X, Y, and Z. We'll follow up the next block 12 hours later. And the benefit of that is they get cleaner data, because that's all they do, right? They'll get every single one of those patients, they touch, they do another block, they do a catheter, whatever. And then I can just look at that data downstream that I can't look at right now, because all my data just stops the minute they leave. But if I have that protocol in place, my data becomes much stronger and much more outcome-based, rather than what it's like pain reduced by 50%, which is all I can get. And my question for you is, for the registry, should we standardize more of our blocks?
Yeah, in terms of, I mean, I don't know. To be honest, I mean, I do think it gives us cleaner data than varying amounts of different anesthetics and analgesics that are being used. But I mean, like, even from us compared to Denver Health across town, right? Like, they don't have ropivacaine accessible because their formulary, it's either too expensive or it's just not on it. So they're using bupivacaine for everything. Whereas for us, we could easily pull Ropiv down. And so it's in all our Pyxuses now. So I worry if we get too protocolized, it inhibits the external validity and external, like, our ability to basically open this to more departments.
But we could say bupivacaine or ropivacaine, weight-based, block needles, 1 hour follow-up, 4 hour follow-up, or whatever the number. Then we'd be like, well, Andrew's like, well, our patients leave in 2 hours, so let's do 30 minutes and 90 minutes. Great. And then I got Epic to build. We got the Epic build that signifies the minute I drop a template, 30 minutes after the template, the nurses get notified, which took me 8 years to figure out, which is crazy. It took me 8 years to figure out. But right when any of you guys do that in your site, you have good data. You have better data, because the biggest flaw in almost everybody's data is pain follow-up. Yeah. No, it's a good point, Dan. You want to see variance in practice, and to see what's out there. I think these are all, this is why I don't know the answer to this, but Joe presented a paper this morning and we're talking about this, the clean anesthesia data. And it bothers me that surgery, cardiology is like, oh, we have such clean data. Like, yeah, because you don't do anything, right? Your patients with LDLs of 184 get a pill, and then they fall up in their clinic and they get a blood draw. You don't do any work. You're just entering patients. You don't even really do anything. You just get the data. Cardiologists get all the echo data. We have to find patients. We're working random shifts. It's a heterogeneous population. And so the more stable our ask is, the more our data can be aligned, so it isn't so random. Because I even look at our data. I mean, what percentage of our analyst paper, what percentage of our patients do we not have pain score follow-ups? It's huge. It's like 20, 30%, which is gigantic. I mean, if we can get that to 95% or 80%, like, all this is publishable. Dan, do you want to explain your point? If you're on vacation and you don't want to, I get it.
Yeah, sorry about the mixed signals there. Yeah, I think a registry, their strength is you're capturing what people are actually doing. And once you dive into that data, you can find, okay, there's a lot of variance in this block with their amount of anesthetic, yeah, there's the people who have ropivacaine and people who have bupivacaine or whatever they have access to. But their dosages are wildly off. Like that in and of itself could generate like a study or at least an area for like a PSA or something. Whereas I think if you want to standardize something, if you have the evidence to say that people outside of this standard are committing some kind of malpractice or inferior practice, fine. I think that's reasonable. However, if they just have a practice pattern or available resources that's causing that variance, I think the registry is there to capture the variance, not necessarily to force people to perform a certain way.
Yeah, I just think of it as like the NEAR registry or other registries. I mean, just so much easier. They standardize some of their protocols of like what they're asking for. Like I'll look at Felipe's TE registry, right? He's asking, he may let you do what you want, but he's asking certain very specific questions. And I think that we have to ask that same thing. I worry that our data is going to be so heterogeneous that we're going to get a lot of mixed signals on this. But I get your point. I think that's a fair point. I just want cleaner data. I know that I can't get cleaner data because of the fact that we all practice a little differently in different shops, and it's hard to collect this population. It's a really hard population.
I actually think the thing that'll be interesting is how. I mean, just looking at the numbers that we've got already, even with, I think we're at 7 or 8 sites now. I think the data is going to be so overwhelmingly from Highland. I think we're almost going to have to do subgroup analysis just of the other sites that are probably, it's going to be like everyone is then equal to you guys in totals, which I think is in and of itself, right, is going to give us some of that variance, but it'll just be interesting to see how that changes some of it too, because I think whatever we're getting from you guys will be what you've got. And that's going to be a primary driver of a lot of the data for the group.
Yeah. Anybody else on the call has protocols in their department, have started, and people who are newer to the process, I'd like to hear, because I think that that's something, if I had to do all over again, I would have been much more, not dogmatic, but instructive to my new learners. And really been like, you have a hip fracture. This is what you do. I'm going to give you, 10 to 15 of bupivacaine, weight-based max. We're just going to use bupivacaine or ropivacaine. And, here's our needles, and make it so simple that my data would have been cleaner. Because it took me a long time to realize that I was just doing one-offs and I was trying to prove to myself that we could do it, but I only prove it by getting large numbers of people. Anybody else have who's a younger program, they're doing this?
Hey, Arun. I mean, obviously I'm not at a younger program, but I actually wrote the protocols and created a task force and submitted to admin, and they totally ignored it for the past month and a half. And so I'm having trouble getting the most basic fascia iliaca protocol through, because I'm trying to standardize it. Because it's being done, but as you said, everyone is all over the place. I went and got ropivacaine in the ED. We should be using these needles and doing it this way, but it's really hard, and I think it's playing catch up, and I think that'll take a few years before we can do some of the stuff that you're proposing. I think exactly, maybe as Joseph had said, that's where I'm at.
Yeah, even for like pain scores, right? Like I think if I could just somehow, if it was, like the nursing initiation at 30 minutes to write the pain score down at 1 hour, if I can just get that on all my blocks, if that was a standard, like a robot could do that, my data would be so much cleaner, right? That just one little thing like that. And it took me a long time to realize that that was useful, because I can never publish data if I don't know pain scores.
Yeah, and to your point, I brought that up with the admin Fedin, and he said there's no way we'll ever be able to make nursing do that, so just write it so the provider has to do it. So that's how my protocol is going in, and obviously, we're not always going to do it. I thought it was simple to ask the nursing to do it, but I guess that was too much of an ask.
Yeah. I mean, I literally built it into Epic workflow, so they're forced to do it, and I'm going to find out how efficacious it is. I have a feeling it'll still be 80%, but it's better than 50%. And all I want is a 30-minute and pain score, because I'm hoping that somewhere in the chart somebody documents at 1 hour or 2 hours.
Our problem is I don't think half the providers do do the actual procedure note until hours after. And so I don't know what I would use as the trigger, because it's like order anesthetic and then there may be a 45-minute delay till the procedure's done. Can't be opening the procedure note either, because that with varying success happens.
So I'm gonna let you finish once again, Joe. So we've forced people, really been pushing them. So on our block template, it has a time, which they push now. And we really have pushed that you have to put the block template after do the block. Obviously, there's gonna be variance in that. But yeah, this is so hard, right? Because this is why our data gets so crappy. I'm gonna let Joe talk for a second.
Yeah, so the other way to do it would just be to build the reassessments into the block note. So you do the block, you share your note, and then you do the reassessment and sign it at like 30 minutes or 60 minutes. That's what we did at MGH, because there was no way nursing was going to do that there either.
Or is it optional to put those in?
The problem we have with that is, I don't know about Epic, but once I drop a note in, you can sign it off. So you weren't signing off that note and then you were waiting for 30 minutes. Because we had 2 layers. My first Epic note was first, pre and post. And nobody ever did the post.
Yeah, I was about to say, unless you make it mandatory, I don't think people would do it.
Interesting. Okay, so you have the time when somebody does the block, they drop the note, and you can't sign it until you get the post. Okay. Yeah.
But that raises its own issues.
Yeah, it's
if
all
you
the
make it
downstream
mandatory.
effect stuff that I don't think about, because you're like, we just want to get people to do blocks. I know you guys all are like, I just want other people in my division to do blocks. That's the goal. And I get it. And it's the education. But then to prove that it's efficacious takes a level of just standardization that I think is really not easy in the way that we practice. Anybody else?
Yeah, Arun, I'm trying to write a block protocol for our hip fractures at Maricopa Medical Center in Phoenix.
We can't hear you, sorry.
Oh shit, sorry. Can you hear me now?
I can hear you.
Okay, so we're trying to write a hip fracture protocol for Maricopa Medical Center in Phoenix. And the problem I have, some of it is actually on the ED provider side, that my older providers, they don't want to learn how to do blocks, basically. So I can't make a protocol where every hip fracture gets a block because I have some providers that don't want to learn how to do them. How did you guys get around that?
I mean,
I'm going to tell you my pathway for all ultrasound procedures. I did this at Brown, I did this at Highland. I just up-trained the residents to embarrass the attendings. It's a horrible thing to say, but residents, I can't think of a resident I know that wasn't excited about doing a procedure. And let's do something like, it's so simple as a femoral nerve block.
Yeah.
So the only thing that was difficult, and I found this more at Brown Hospital than I did here, just because we have a smaller group of physicians, and it's not because anything else, there's 80 or 100 physicians there, is that some attendings are like, no, you can't do it. I'm the attending, you're not going to do it, which is,
Yeah.
it's not, because it's just the ethos is that the residents know how to do all these procedures. So I think having residents really excited by this tended to shame the attendings, who then just like, okay, I'll come watch. And that's what happened when I was around hospital.
Yeah.
Any other thoughts?
The other thing that I've been using to push this is that the cool kids down the street are doing it. I mean, if this is, I have to say the institution MGB is doing so many more, and their outcomes are awesome. But in general, a lot of hospitals and big systems are starting to pick it up, and as that becomes standard of care and they have a lot of success with it, then you start to just be behind, which is, I feel, a way a lot of hospital admin makes decisions. We're starting to see that.
That is 100% correct. The reason we had ultrasound at Brown was because of the fact that I literally printed out all the other hospitals in the area, and I only picked the Ivy Leagues because that's all they cared about. And I printed them out on a piece of paper. I'm not kidding you. And I listed what ultrasound they had going in the department. And I presented it at credentialing, and they all looked at it and said, oh, if Penn's doing it and Harvard's doing it, we have to do it. And literally that was the conversation, which is embarrassing, but administrators around a table are the worst people in the world.
Josie, the other thing I've had, I've had success with is our departments. I think we've got 5 different pods that are running at any given moment. And I usually just, before I get there, I just send out a blast on like secure chat that to both the residents and the attendings of like, hey, I'm here. If you have any blocks that you need help with or you want supervision, let me know. And then similar to, I think Arun had a group that wrote up for ASAP Now a little while ago. I've got now 7 or 8 resident nerve block champions that are all looking for times and ways that they can help do it. And so they're, if nothing else, the faculty all sort of know that, hey, these 7 people meet with me quarterly. We talk about the blocks. They know what to do. They can help walk you through it. And it kind of gives them like a separate status within faculty discretion that like, oh, these people have done extra training, which I think has also gotten some buy-in. That's gone pretty well.
Yeah, that's smart. I gotta start with the residents then. I'm going about this the wrong way.
Yeah, I mean, we trained attendings, we did attending courses. I stopped. I refuse to do them anymore just because it's such a waste of time.
Yeah, it's like nobody comes and there's like no interest. I can't generate any traction.
Yeah, residents are the key. They will learn it quickly because they're still trying to get skill acquisition, and they listen to podcasts and read all the blogs. And once they start, yeah, the Cadaver Lab, we used to do Cadaver Labs. I stopped doing because there was such a huge lift. If you're at a big academic institution that offers it, it's great. It's just a big lift for most sites. I like Tofu. I think Tofu hitting an object is probably good enough, but I'm also a pretty low sim person.
We're doing Josie, I'll let you know in like 3 months. I think we're gonna do we've done these sessions with the residents where we just call them blocks and brews, where we choose a different block. One of the faculty members hosts, and we do like beers and food, and then they come through. So we're gonna do our first faculty edition of it because I was having the same thing where I couldn't get any faculty to show up. And so we partnered with our post-COVID wellness committee for the faculty specifically, and so we're trying, this is like a different, not after conference, not after anything else, just to see and make it a little bit more social, I guess. But that's, yeah, I'll let you know how it goes.
I'm just kidding. One last thing to kind of round it up. So if you're starting a block program or moving forward with looking at research into your block program, think about protocolizing it just so you get cleaner data, because my data was so crappy. And I think the more you do it, even like I think Mazin just pointed out they're doing stuff from rib fractures. We've done hundreds and hundreds, and like you just said, they've been great. Everybody blow in a little tube and get pulmonary function tests, and all the blocks that were done at Highland. If I would just thought about it 5 years ago, that would have been published data. But instead, now we're like all thinking about this. So if you're going to move forward in this, just think about ways of looking at your research, or at least your data, in a front to back way, and it'll make your life much easier because you'll prove it internally, and then you can prove it externally.
That's smart.
Yeah.
Blocks.
Anyway, thanks everybody. Sorry, Dan, to pull you off vacation.
Sorry that